Welcome to the long-term care office hour call for May. This call is hosted by several partners. It's a collaboration between the Alabama Nursing Home Association, the UAB Nursing Home and Long-Term Care Facility Strike Team, Alliant Health, which is our quality improvement organization, and the Alabama Department of Public Health. We've got a presentation for you guys today that's going to focus on enhanced barrier precautions. And then we will open it up at the end of that presentation for live Q&A. So feel free to type your questions into chat or come off mute and ask your question as well. We have some support from our regulatory agency. We've got Denise Millage and Felicia Williams on the call, and so they will be here to answer any regulatory questions. And then we also have Candy Easterling on the call from our life safety team, and she's going to do a short discussion after Wade does his initial talk on enhanced barrier precautions. So with that being said, I will go ahead and pass it over to Wade. Thank you.
Thanks, Melanie. Good morning, everybody. Like Melanie said, we're going to talk about enhanced barrier precautions, a lot of the frequently asked questions that were received, and then open everything up for a live Q&A. So just before we get into that, just to go over a couple things, enhanced barrier precautions. CMS issued new guidance, the QSO 24-08-NH on March 20th, 2024 for enhanced barrier precautions in long-term care facilities. What that did was to align with nationally accepted standards from the CDC that become effective on April the 1st, 2024. So we're a little over a month into enhanced barrier precautions being implemented now. What it's for is the use for residents with infection or colonization with CDC targeted MDROs. And can include other epidemiologically important MDROs, those residents with wounds and or indwelling medical devices. On the other epidemiologically important MDROs, facilities do have discretion about including those MDROs in their enhanced barrier precautions plans. And then with all this new guidance, many questions have come forward on how and when to implement enhanced barrier precautions, and that's what we're here today to talk about. Facilities do have some discretion in the use of enhanced barrier precautions to maintain a home-like environment. And then this new guidance related to enhanced barrier precautions has been incorporated into the FTAG at F880, which is Infection Prevention and Control. Also recently received the updated critical element pathway that discusses enhanced barrier precautions. So with that, getting right into the frequently asked questions, the first one is what exactly the targeted MDROs are from the CDC that distinguish who needs to be on enhanced barrier precautions. This person's seen a list from the CDC, but are those just examples? So what we've included on the slide is examples of those targeted MDROs, as well as those other epidemiologically important MDROs. And the answer to this is the first list of CDC targeted MDROs would be calls for enhanced barrier precautions in your facility. The lower list may be considered as well, but your regional and or local health department may want to target those additionally epidemiologically important MDROs, depending on what's going on locally to you, and available treatment options for those. Studies have shown that often in nursing homes, MDROs that you are aware of are only the tip of an iceberg, and that further supports, using enhanced barrier precautions when transmission risk are present in any resident with medical devices or unhealed wounds. For example, while MRSA is not considered targeted by the state and the CDC, it could be added to the facility-specific organisms if there's higher risk identified, if the facility experiences higher rates of MRSA bacteremia leading to hospitalizations among residents. They may also want to consider using enhanced barrier precautions for anyone with a history of MRSA as well. Next question, do I have to place a NAERS positive resident on enhanced barrier precautions where they would not have wounds or an indwelling device? The answer to this is residents with targeted MDROs should be on enhanced barrier precautions. Your facility's medical director Infection preventionists and other experts must review the list of other potential MDROs like MRSA, ESBL, among others, and decide which warrants enhanced barrier precautions. That needs to be then included in your policy that explains the approach and the rationale for including those. Many nursing homes will receive post-op residents for physical therapy and other needed surgical services. The guidance on when to apply enhanced barrier precautions includes examples of chronic wounds, include but are not limited to pressure ulcers, diabetic foot ulcers, and unhealed surgical wounds, as well as chronic venous stasis ulcers. For these post-op residents, for instance, a post-hip replacement with fresh post-op surgical wounds, would they be considered unhealed? And we got this response from Dr. David Gifford, who's the Chief Medical Officer for the American Healthcare Association. And his response was the use of chronic wounds by the CDC in the FAQs, as an example, was not meant to say that only chronic wounds trigger enhanced barrier precautions. It's the characteristic of the wound that matters. Wounds that are likely to serve as a reservoir for MDRO colonization or a portal for infection are what matters. New post-op surgical wounds that are well approximated and may or may not require addressing do not trigger enhanced barrier precautions per CDC's comments and discussions with CDC. However, an open surgical wound, such as a new post-op surgical wound that is being allowed to granulate or a surgical wound that has recently dehisced, would trigger. A surgical wound with a drain would trigger as it has an indwelling device. And then CDC guidance allows some clinical judgment of individual providers, as it is not possible to list all the different situations that could arise in a skilled nursing facility. There is concern about how CMS and state surveyors will question provider clinical judgment. Surveyors will be looking at your policy and procedure on how you are making decisions. So you need to document in the residence records why you've decided to or not to trigger enhanced barrier precautions for situations that are not specifically mentioned in the CMS or CDC manual. What if a resident or family member is refusing enhanced barrier precautions in your facility? What can the facility do? So this response was received directly from CMS, and residents and families cannot refuse certain practices that are to protect the health and safety of staff and other residents when the practice does not directly require the resident to take or do something. Enhanced barrier precautions does not impact the resident directly, therefore they cannot refuse. And ultimately, the benefit of the building outweighs the resident rights. Can facilities place a piece of colored tape or dot on whatever they choose on a resident's door to indicate a resident is on enhanced barrier precautions instead of using the glaring CDC enhanced barrier precaution signage? Answer to that was per the CMS QSO-24-08-NH. It is at the facility's discretion how they communicate with staff about who is on enhanced barrier precautions. So yes, they could choose how they want to do this as long as they ensure all staff are aware of which residents are on enhanced barrier precautions and that their policies match. So what they're going to be looking for here is that what your policy says, that you've educated your staff on how to recognize who's on enhanced barrier precautions. The next question come in about PPE storage. There were concerns about dignity issues if signage or supplies can be seen from the hall. So this was kind of a two-part question. So the first part, can gowns be stored in the resident's room with the gloves instead of carts in the doorway or at the doorway? And then the second part of that question is it okay to put enhanced barrier precaution signs and supplies inside of the room? So the answers to these is yes, the PPE may be stored right inside of the resident's room. Storage of PPE for the use of enhanced barrier precautions only within the room is acceptable as long as the facility can avoid contamination and it is not used for another resident. And it is okay to place signs to ensure infection control practices are communicated to staff. And that goes back to our question just right before this one. If a resident meets enhanced barrier precaution criteria and is receiving therapy in the hallway for ambulation, should the therapist be wearing the PPE? So the answer to this is PPE is not intended to be worn in the hallway unless there is a specific threat, such as a potential exposure to blood or body fluids. The overall focus of enhanced barrier precautions is related to the prolonged close contact care which is often bundled together. Enhanced barrier precautions is primarily intended to apply to care that occurs within a resident's room where high contact resident care activities, including transfers, are bundled together with other high contact activities, such as part of morning and evening care. This extended contact with the resident and their environment increases the risk of MDRO spread to the staff, hands, and clothes. And just a review of those high contact activities, those are dressing, bathing, showering, transferring, providing hygiene, changing linens, changing resident briefs, or assisting with toileting. And that also includes device care or use, such as central lines, urinary catheters, feeding tubes, tracheostomies or ventilators, and wound care. Any skin opening requiring a dressing. The statement directly from the CDC call stated that enhanced barrier precautions are primarily intended to apply to care that occurs within a resident's room. Then outside the resident's room, enhanced barrier precautions should be followed when performing transfers during bathing in a shared common shower room and when working with residents in the therapy gym, specifically when anticipating close physical contact while assisting with transfers and mobility. To reduce the risk of transmission, the provider and resident should perform hand hygiene, ensure any dressings are clean and dry, and that any secretions or excretions are contained before leaving the resident's room. This is sometimes referred as the 3 C's. We want to cover, clean, and contain. If therapy needs to wear PPE, is there a period that contact is made that makes it high contact versus not? Can one facility call it high contact and another not? The facility should have a policy that addresses this question. Generally, if staff are having close body contact between their clothing and the residents, that is a high risk for the potential to spread organisms from contaminated clothing. The policy should have a rationale for when and why enhanced barrier precautions is used. Again, staff should be trained on this policy and be able to show it to a surveyor. One question we got was, is it okay to have disinfectant wipes in bins, such as the plastic 3-drawer bins in the hallways that facilities are using for enhanced barrier precaution PPE? And there is no specific guidance that advises against this. This question come in that the facility has a resident with a dialysis port, no fistula or central line. And the question was, does this individual need to be on enhanced barrier precautions? The answer to that is devices that are fully embedded in the body without components that communicate with the outside, such as pacemakers, would not be considered an indication for enhanced barrier precautions. So, if the dialysis port does not have a component that communicates externally, the resident would not have a recommendation for enhanced barrier precautions to be used unless they have another reason or criteria for that, such as an indwelling device, wound, or MDRO that would have them meet that criteria. Do we place everybody or everyone with a history of a targeted MDRO on enhanced barrier precautions, or only people who are colonized? This question is in reference to people who don't have an indwelling device or an open wound or any other reason that would put them on enhanced barrier precautions. The only thing is they have a diagnosis of a history of having an MDRO. And in short, the answer is yes. Anyone with a history of a targeted MDRO should be placed on enhanced barrier precautions. Intermittent positivity is likely for those with a history of MDROs, and although the indwelling device has been removed or the wound has healed, for example, these individuals most likely are colonized on other parts of their body. Therefore, the best practice is to ensure enhanced barrier precautions is maintained despite having been treated and or receiving negative test results. The concept of risk recognition should be the focus when deciding whether to apply interventions such as enhanced barrier precautions. During an individualized resident assessment, there may be several factors to consider, such as, is the resident immunocompromised with chronic illnesses? How long has their healthcare stay been? And do they have other risk factors, such as currently being on antibiotics? These all would increase the risk of being colonized with the previous history of the MDRO, and thus be recommended for enhanced barrier precautions. What PPE would require to administer medications through a feeding tube? Enhanced barrier precautions is recommended for the care and the use of a feeding tube. The safest practice would be to wear a gown and gloves for any care or use, such as injecting or infusing medications or tube feeds in the indwelling medical device. It may be acceptable to use gloves alone for some uses of a medical device that involve only limited physical contact between the healthcare worker and the resident, such as passing medications through a feeding tube. This is only appropriate if the activity is not bundled together with other high contact care activities and there is no evidence of ongoing transmission in the facility. Facilities should define these limited contact activities in their policies and procedures and educate their healthcare personnel to ensure consistent application of enhanced barrier precautions. Where should it be documented that education to the residents has been provided? So it would be recommended to document in the resident's medical record the education that was provided to them. If, again, knowing our resident population, if the resident's cognitively impaired, it would be recommended to document that education has been provided to the resident representative. Can PPE used for enhanced barrier precautions be thrown away in regular trash, or does it need to go in red bagged waste? And here you should refer to your local and state regulations regarding disposal of medical waste. The OSHA bloodborne pathogen standard uses the term regulated waste to refer to the following categories of waste which require special handling. And that's at a minimum liquid or semi-liquid blood and other potentially infectious materials, contaminated items that would release blood or other potentially infectious material in a liquid or semi-liquid state if compressed, items that are caked with dried blood or other potentially infectious materials and are capable of releasing these materials during handling. Of course, contaminated sharps, pathological and microbiological waste containing blood or those other infectious materials. And then based on that definition, most PPE used during resident care, including the care of residents placed in enhanced barrier precautions or transmission-based precautions, would not fall into this category of regulated medical waste that would be required to dispose of in a biohazard bag. Thus, could be discarded as routine non-infectious waste. Facilities should remember to have an appropriate disposal container available in the resident room to allow for removal of PPE inside the room. However, local or state regulations may be more restrictive than this federal standard, so you should refer to those when making decisions. Does a resident with an ostomy require enhanced barrier precautions? Per standard precautions, use of PPE, such as gloves, would be indicated if helping a resident change an ostomy bag. However, presence of an ostomy would not be an indication for enhanced barrier precautions. And this response was provided directly from the CDC. Dignity issues. So we got several questions regarding dignity issues, and here's 3 of those. Is walking a resident requiring contact guard assistance down the hall with gown and gloves or wearing a gown and gloves during therapy prolonged exposure a dignity issue? If this is causing a resident to be embarrassed and the resident is a reasonable person, would the facility receive a citation for this? And then lastly, with the new psychosocial severity outcome guide being used in surveys, how would you address this being a dignity issue and potential harm to dignity of a resident who is living in a long-term care facility? And here's the answers to these. Our understanding of healthcare transmission of organisms is evolving, and enhanced barrier precautions is a response to that. It will be important to explain to residents and families what you are utilizing enhanced barrier precautions for, and that it is used to protect the person you are caring for as well as other residents in the building. There are templates on CDC's website that can be used for communicating with residents and families on enhanced barrier precautions. So at this time, I'll turn it over to Candy Easterling with Life Safety on how Life Safety Code may affect the facility's implementation plans for enhanced barrier precautions. Candy?
Good morning. Hey, thank you, first of all, for y'all inviting me, and I appreciate it. So there's just a few things that involve life safety and all of this, and just want to go over them, and then if anybody has any questions, be more than happy to answer. So having the PPE brings on what to do with it after you've used it. And according to a lot of people I've talked to, they are looking at doing it in the room since that's what is allowable by CDC and CMS, that you don't have to don or doff outside the room. You can do it inside the room, and of course, for the patient's privacy. So trash can size or sold linen size, the code will only allow up to 32 gallons without then having to turn the residence room into a hazardous room, which you don't want to go there. So make sure you get containers that are 32 gallons or less if for putting them in the room, okay? The second question bearing on that is that if we use a red bag that is larger than 32 gallons, will that be a problem? And so as long as the red bag is in the 32 gallon or less container, you're okay. But like, let's say that container gets full, and like we do at home, we take the trash bag out and set it beside it so we can get some more in it. That would be a problem. You wouldn't be able to do that. You would need to remove that that bag and put a new one in. Also, have been asked by people if they can use door hangers that contain gowns and gloves on the residence room corridor door. Let's start there. And yes, you can. What you need to make sure is that the door will close and be smoke resistive, that there won't be a big gap. Okay, so if you find one you like, you may want to buy one or two and try them on your doors before you buy a whole bunch. Also, we were asked, could y'all put these hangers on the bathroom door from the resident's bedroom into the bathroom? And yes, you can. Yes, you can. That's totally allowable. And then you do not have to worry about the smoke resistance either. So that's totally doable. I think those are the few questions that I have been asked, just trying to get everybody on board. So we're taking care of the life safety part too, and not receiving any unwanted, unnecessary tags on our part, trying to do what is right for the health side. So anyway, that wraps me up. And unless someone has questions, I will turn it back over to somebody.
Hey, Candy,
Yes.
we did have a couple questions that come in
Okay.
specific to enhanced barrier precautions. And as just a reminder, this is our time for live Q&A. So if you have questions, place those in the chat or the Q&A section on the call. And let's see. The first question specific to life safety: is the trash can in a room required to have a lid?
No. No. We wouldn't require it. Now that would not be for, let me clarify. We got plenty of health team people here. For life safety, it wouldn't. If the health team, because it may have some infectious control, then maybe on their part. So that might be a twofold to get somebody from that side to what would they think. But as a life safety, no, would not be a life safety problem.
Denise, would that be any concern from HPS?
No, it would not, as long as they follow the regulations as Candy outlined them.
Thank you. Another question that come in: what, if any, isolation should you place non-targeted MDROs such as MRSA or other drug-resistant organisms?
I can take that one. So For your non-targeted MDROs, such as MRSA, you can use enhanced barrier precautions if your facility decides to implement EBP for the other epidemiologically important MDROs.
Next question. Per CDC, PPE cannot be kept inside the resident's room for risk of contamination. And I think this goes with it since it's for EHB. Maybe since it's for enhanced barrier precautions.
So this is Amy. I'm trying to find the CDC FAQ. They say they don't say can or can't. They say, refer to best practice and what they recommend. So there is no can or can't. What Wade referred to in his presentation would be ideal, right? Or it is allowable to have it in the resident's room. However, there is risk for contamination. So CDC is going to refer to the best practice of storing it outside the room as their recommendation.
Felicia wanted to make a comment if we could, please.
Yeah, absolutely.
We would also, from a regulatory standpoint, we would look at the best practice also. We wouldn't automatically say that we would disagree with it being in the room if it's the best practice. So I agree with there's no right or wrong. There's no yes or no answer to that, depending on the situation. We would not automatically agree with it should be in the room.
Thank y'all for that.
Mhm.
Okay. Next question. Do we need to place a resident on enhanced barrier precautions for a surgical wound that is not draining?
I can go ahead and take this. We talked a little bit about whether or not EBP, what types of wounds EBP needs to be used for. And I think it just goes back to the characteristics of the wound. If it can serve as a source of colonization or infection, then it would meet criteria for EBP. If it is draining, then that would be an indication for contact precautions. But again, looking at your resident and doing an individual risk assessment is going to help to determine whether or not the wound that they have is meets criteria for enhanced barrier precautions. But just generally, if it can serve as a source for colonization or infection, then err on the side of precautions and implement EBP.
Wade, this is Leanne. Can you go back to your slide where CDC did respond to us about keeping the enhanced barrier, the PPE in the room? Because they did say that it could be in there, but it was for enhanced barrier only.
Is that what you were looking for, Leanne?
I believe so, because they didn't mention into a call one day, if you can avoid contamination. So that may be the issue that Felicia's referring to, because I believe ADPH also had previously stated that they would go by the QSO, which does allow for it to be in the room.
That is correct.
Yes, that's correct. We agree with that.
And this is Amy, just from an implementation standpoint, right? It's the standardized practice and consistency, right, of the visual indicator. If the PPE is outside the door, is very helpful for the staff to know when PPE is required prior to entering the room or completion of a task, right? So they get that visual indicator. You also have kind of that same setup for rooms for residents in contact precautions or droplet precautions or enhanced barrier precautions, right? So you kind of have this nice standardized approach, which I feel like is very important for the implementation and the compliance with following the precautions. So if you are considering doing that, I just would consider how are staff going to comply and have what they need available to them? And is the consistent practice and that standardized practice going to be helpful to improve compliance?
Another question that come in concerning MDROs, Would MSSA be considered an MDRO?
And Amy responded in the chat. So MSSA would not be
Oh,
considered an MDRO, but it's considered to be an epidemiologically important organism. So again, based off of, you know, the MDROs that you, or the infections that you typically see in your facility, if you are using EBP for the other epidemiologically important organisms, then that would be one of the ones that you would add to your list for implementation of EBP. And there's another question in chat. It's about the slides, if we can get it, if the facilities can get a copy of them so that they can refer back in the future. And yes, this is recorded and the slides will be posted on the ARC-IPC resources webpage.
Some more questions in the Q&A. Is there any instance outside of a resident's room, shower room, or therapy room that you would use PPE for residents on enhanced barrier precautions, toileting/transfers during outings, high contact hallway ambulation, assisting a resident that has fallen and needs assistance to get off the floor in the dining room, or assisting a resident to transfer into a family car, etc.? It's kind of long, so.
Yeah, I was just thinking through each of those examples given. So again, you know, PPE is not intended to be used in the hallway and is really meant to be used for those prolonged bundled activities. So for the example of assisting somebody who's fallen and you're helping them get back up, I wouldn't consider that to be a prolonged exposure where you're, you know, it's going to be a very short time that you're going to be having contact with that resident. High contact hallway ambulation, or assisting a resident to transfer into a family car. I'll just reiterate that EBP was intentionally meant to be used in a resident room when you've got those bundled activities and there is that prolonged high contact. So if there are instances where you've got a resident outside of their room and you know that resident is on EBP, just more often than so, if you're just assisting them to get from one place to another, EBP is probably not going to apply. Any other thoughts or comments about that? Feel free to chime in.
Can we get Melanie, Felicia, Leanne, Denise, and Candy's phone numbers to ensure we have the correct number in case we have additional questions?
Yes. We can
Yes.
type our numbers into chat.
Yeah,
Yes.
that's fine with us as well.
Does ESP need an MD order and to be on the residence care plan? EBP, not ESP. There was on down in the Q&A. So does enhanced barrier precautions need an MD order and to be on a residence care plan?
I would think, you know, you're going to have to document justification for using EBP on each resident. As far as and that might be included in your resident care plan, but as far as an MD order, I don't think so. Somebody else, please help me out.
I would agree that would not need an MD order. And you know, your policy would dictate the justification of when that is applied. But would definitely also defer to regulatory bodies on that one too, if an
Right.
MD order would be required.
Yeah, we do agree that it would be part of the facilities policy and at their discretion based on that particular resident, the need of that resident. But yes, also that it would be a part of the care plan.
This question is, I know this question may not be appropriate for this webinar, but has CMS made a statement regarding the financial impact on facilities with the amount of PPE that will be used going forward? Is there going to be any increase in payment for residents on enhanced barrier precautions?
This is Katrina. I have not seen anything that came out regarding the amounts of monies or any increases given to facilities for additional PPE for implementing enhanced barrier precautions.
Thank you, Katrina.
This is
And-
Denise. We have not as well.
Thank you,
And-
Denise.
This is Amy. I'll just add to, as you're determining which organisms, including the targeted and the epidemiologically important organisms, if you include all of the MRSA and ESBL and all of those things, you're going to have a lot more residents in EBP. You might have less compliance because if you have a large population of residents in enhanced barrier precautions, that's just overwhelming for staff and is going to be more costly. So really using a good risk assessment for which organisms you're going to include, aside from those targeted organisms, might be a really good approach to not only improve compliance with following EBP, but to also, save cost and make sure that you are justifying which organisms you're putting into EBP.
Next question. What if the MDRO, for instance, ESBL in the urine is being treated, but is contained by a brief, we use EBP, not contact? Only time contact while treating MDRO is when it is not contained. Is this accurate?
So this is Amy. This would be if we have an infection, an active infection. So if they're under treatment for an MDRO, you would follow the CDC Appendix A for that organism, that infection, which would require, I believe, contact precautions for the duration of the infection in this case. So you would refer to CDC Appendix A for any active infection for which type of precautions and the duration.
Why are hospitals not using enhanced barrier precautions? There is a high risk for transmission there, not only in long-term care facilities.
While hospitals are not using EBP, they do use contact precautions for any of the patients with an MDRO. The whole creation of enhanced barrier precautions was to support long-term care facilities, because enhanced barrier precautions are to be used for the duration of the resident's stay or time in the healthcare facility. Knowing that the current isolation guidance for MDROs is contact precautions, there were discussions and a decision that contact precautions for a resident's, rest of life or duration in a long-term care facility was not feasible. So that was the discussion that started everything with using enhanced barrier precautions, and that guidance only being applicable to long-term care facilities. It's not as restrictive and it's a little bit easier to implement while still protecting the residents and staffs from these targeted MDROs.
Next question. Does a patient with an MDRO from over a year ago still need enhanced barrier precautions?
So while the CDC guidance doesn't give a specific time frame, as far as, if a resident had it 6 months ago or a year ago, then, transmission-based precautions wouldn't be applicable. What we do know, especially, I'll just give an example for Candida auris, once somebody's infected or colonized with that organism, they can serve as a source of transmission for over, a year's time. It could be, I think even there was some study done and it was on people who were colonized with C. auris infection or colonization, and they continued to show intermittent positivity past the 2-year mark. So I think as a general rule, if they have a history documented of an MDRO, there's no time frame to consider. You just know that they've had the MDRO in the past, and there's a chance that they could become positive at any time. And so transmission-based precautions would need to be implemented for that resident.
There is much reference to a risk assessment. Has there been a tool developed? And I know Amy Ward said she would like to take that question.
I just dropped the CDC risk assessment tool into the chat box for everyone. And, you know, on the infection events, there is an outbreak related section towards the bottom. You can add line items. So any additional MDROs, they just have a general MDRO and says specify. So you can add line items for each MDRO to risk assess all of those epidemiologically important organisms that you may be seeing in your region, in your facility, maybe contributing to a higher level of hospitalizations among your residents, for example. Maybe the hospitals in your area see higher levels of these MDROs. So I would utilize that tool to risk assess each of those and determine what's going to be important for your facility.
Thank you. Do have 2 more questions. The first one is, I know there's been a lot of discussion about storing PPE inside the room. What about storing PPE for enhanced barrier precautions inside of the bathroom?
So this is Amy. I'm just going to jump in, and I think you can store some PPE in that situation if you need it for standard precautions in general, but definitely inside a container of some sort. So when it become contaminated, right? You wouldn't want to just leave it setting out in an open space in the restroom. But if you are in there for some reason and need to, you know, put on PPE for standard precautions, it might be nice to have that available.
Last question that I have is, does the CDC consider midlines as peripheral IVs for the purpose of enhanced barrier precautions? If so, the midline would not need enhanced barrier precautions. The midline is longer than a peripheral, but is listed as a type of peripheral that stays in 2 to 4 weeks instead of 72 hours. So the question is, does anyone know if CDC considers midlines as peripheral IVs for the purpose of enhanced barrier precautions as an implanted medical device?
There was an actual question on APIC about that. I'm trying to find it. Hold on.
I would say it's an indwelling medical device. You know, it does have a longer duration than a PIV. So I look at risk, right? If you're talking about the risks, it does have a longer dwell time. So certainly more risk than a peripheral IV, but maybe a little bit less risk than a PICC line.
What is a good guideline for wounds with enhanced barrier precautions?
Are you asking how to identify wounds that need EBP? If so, then CDC has a couple of examples listed as wounds that would need EBP, but again, it's not inclusive and it's going to be based on the assessment of that particular resident. So based off of the characteristics of the wound, and if it can serve as a reservoir for MDRO colonization and infection, then, you know, err on the side of precaution and implement transmission-based precautions, either EBP. I know that's probably not as specific of an answer, but it's, as mentioned on the website, it's really hard to think of all the different scenarios that residents would have in long-term care facilities. So it's, again, like we've been talking about, conducting that risk assessment and documenting the justification for placing on EBP or not to place on EBP.
Wade, I did find the reference on the Long-Term Care National Infection Prevention Forum it was yesterday morning, someone asked about a midline, and one of the APIC consultants stated that according to NIH, a midline is not considered a central line because it can be inserted at bedside without use of radiography. The CDC guidance only mentions central lines, therefore I would not include the midline in enhanced barrier precautions. But as Amy said, you may want to look at risk.
I think, what is the midline being used? What medications are being infused through the midline? I mean, is the resident at a higher risk for acquisition? It is an indwelling medical device, right? Just like a peripheral IV is. So if you're not using EBP for peripheral IVs, but you are using EBP for central lines, I think just understanding the difference in why you're using that application, and then the midline is kind of somewhere in between. So if they are at high risk, for if they're getting chemotherapy drugs and immune compromised, and you're utilizing that midline, in that circumstance, they're going to have an even higher risk and a direct route through the midline. So, applying it based on risk.
Amy, I do concur with you, but I just know a lot of our members also are on that forum. So I just wanted to,
Yes.
there's two answers out there.
Yes, and I don't think it doesn't sound like there is a concrete black and white answer to a lot of these things. Just as Melanie was saying, we can't define every situation, and so we have to think about what are the risks and what are the benefits of the situation, and do the best that we can in each situation.
You are correct.
Denise, does health provider standards have any different opinion on that?
No, we're in agreement with what's being said. We can't lump everything into one particular situation. It does require assessment of the particular resident, the situation, and what's going on with them. And part of that is where they would work with the staff as far as how they would utilize the barrier precautions.
Absolutely. Thank you, Denise.
There's a comment in chat. I think having the setup in the room, not bathroom, because the staff might not look in the bathroom because the sink is in the middle of the room. Yeah, I think, again, where you set up your PPE is going to be based on feasibility, and as long as it's stored correctly to prevent contamination, it's as we've discussed, it's going to be up to the facility where they decide to store the PPE for EBP.
We thank you for being with us today. We hope we answered all your questions and answers. Again, the next office hours is to be determined, and it will be included in the Alabama Nursing Home Association's weekly roundup. And thank you for being with us today.